In this video, we will review the basics of the electroencephalogram, or EEG, how it's recorded, and how the results can be used in clinical neurology. We will review several topics briefly during this video. The topics will be reviewed in further detail in subsequent videos for those interested in deeper dives into the world of EEG. We will review some of the basic terminology of EEG, how EEG is recorded, how EEG is displayed for interpretation, some common EEG patterns, and how we can use the results of EEG for making decisions in clinical neurology. First, we will start with the terminology. The system by which EEG electrodes are applied to the head and then displayed on EEG recordings is called the International 1020 system. The International 1020 system is a standard method of measuring the head and placing electrodes. It depends on four main positions on the head that are easily transferable between patients. First is the nasion at the bridge of the nose, then the inion, the bony prominence at the back of the head, and then two preauricular points just anterior to each ear. Consider this diagram of a head looking from the top down. The first measurement that is made is from the nasion to the inion, front to back. This measurement is then divided into 10 and 20% increments, and this is how the 1020 system gets its name. Marks are placed, and then a measurement is made from one preauricular point to the other. Again, this is divided into 10 and 20% increments, and additional marks are made. Further marks are made around the circumference of the head, and separated by 10% increments. And then parasagittal measurements are made, separated by 25% increments. And finally, transverse measurements are made. The intersections of these two lines is where the final electrodes are placed. Once all of these marks have been placed, the electrodes can be applied to the scalp of the patient. The electrodes are labeled as is shown here. The system is very simple, and each electrode is represented by letters and a number. The numbers indicate the side of the head, so that odd numbers are on the left side and even numbers are on the right. In general, lower numbers mean that the electrode is closer to the midline, so you can see here that C4 is closer to the midline than T8, and the midline itself is represented by a Z, which stands for 0. The letters are indicators of the position on the head. In this central chain of electrodes, you can see that the F stands for frontal, the C for central, and the P for parietal. EEG is recorded using the technology of the differential amplifier. The differential amplifier takes two electrical inputs and displays the output as the difference between the two inputs. This is particularly useful at recording and displaying very small electrical signals, such as those in EEG. For example, you can see these two waveforms, which are very similar, except for one small difference demonstrated here in red. When these two signals are placed through a differential amplifier, you can see that the output is simply the difference between them, and all of the other commonalities are canceled out. Another way to think about this is to think about the very common children's game that is seen on restaurant menus. You can see that the picture on the left and the picture on the right are very similar, except for a few small differences indicated here. If we were to consider the picture on the left as input 1 and the picture on the right as input 2, we could put these two quote-unquote signals through a differential amplifier, and the output would look like this. This example is a good way of thinking about EEG signals as something that is not absolute, but rather the difference between two inputs. EEG can be displayed in different ways, which are all known as montages. The most common type of montage is a bipolar montage. Here, I have a picture of the head from the top down. If we display the difference between FP2 and F8 as a single tracing, it would look something like this, and we call this single tracing a channel or derivation. Next, we move posteriorly and look at the difference between F8 and T8 and display this as a different channel. We continue to move posteriorly, and we have a string of recordings from the front of the head to the back that are linked together. This string of recordings is called a chain. In this case, this is the right temporal chain. Several chains can be placed together in a single display, such as this example of an anterior-posterior bipolar montage. This anterior-posterior bipolar montage is laid out as if we are looking at the top of the head of the patient and they are facing to the right. Therefore, we first see the left temporal chain, then the left parasagittal chain, then the midline, then the right parasagittal chain, and then the right temporal chain. At the bottom, we see a single EKG channel as well. Another common type of montage is called a common average reference montage. Here, in a single channel, rather than looking at the difference between two adjacent electrodes, as in a bipolar montage, we look at the difference between an electrode of interest and an average of the signals of the rest of the head. Here we can see the layout of an average reference montage, which is very similar, but again we are comparing each channel to an average of the rest of the head. Some relative strengths and weaknesses of different montages are reviewed in a separate video. I will briefly review some commonly encountered EEG patterns, simply to whet your appetite for further EEG learning. One of the most commonly encountered entities on an EEG recording is an eye blink, and so I will review this briefly. We have to think about the eye as a dipole with a polarity. There is the retina and the cornea. The retina is negatively charged, and the cornea is positively charged. If we think about something as simple as an eye blink, in this crude diagram, when the patient blinks their eye, the eyeball moves upward into the head, a phenomenon known as a Bell's phenomenon. This is the normal response during eye blinking. If we think about this from the perspective of the EEG electrodes closest to the eye, we can see that this upward deflection of the eye will cause a large positive signal at the frontal polar electrodes FP1 and FP2. On EEG, this results in a very large deflection in the frontal polar electrodes on both sides, indicated here. The alpha rhythm is the most commonly encountered rhythm during wakefulness. Here I have highlighted the alpha rhythm. The alpha rhythm is a normal rhythm during wakefulness and is especially prominent when the eyes are closed. Although there is a range of frequencies for the alpha rhythm, it is usually around 10 Hz or so, which is the case in this patient. Focal epileptiform discharges are generated by synchronous abnormal electrical activity in a large population of neurons in the cortex. Focal epileptiform discharges can be an indicator that the brain is capable of generating seizures and can be a helpful prognostic and diagnostic finding in patients with epilepsy. Here I have a normal awake EEG in an anterior-posterior bipolar montage. Without going into too many details, there is a focal epileptiform discharge here. You can see that this is in the left temporal chain. I will go into how to sort out the polarity of this epileptiform discharge in a separate video, but here I've indicated the areas of maximum abnormality for this particular epileptiform discharge. Here is a slightly different focal epileptiform discharge. Whereas the other discharge was maximal in the temporal region, this discharge is maximal in the posterior aspect of the head, on the right side, and I have shown its maximal field in this diagram. Generalized epileptiform discharges are seen in patients with generalized epilepsy syndromes. Here is an example of a run of generalized epileptiform discharges. You can see that these discharges involve basically the whole head all at once. There is a long run of these discharges lasting almost the entire length of this page. These are actually the typical 3 Hz generalized spike and wave discharges seen in childhood absence epilepsy. It is useful to think about the diagnostic yield of EEG. In studies of patients with epilepsy, the likelihood of finding an epileptiform discharge, either focal or generalized, in a single EEG within 24 hours of a first seizure is about 50%. If the EEG is done more than 24 hours after the first seizure, the likelihood might drop somewhat. This means that half or even more than half of patients with epilepsy might have a normal routine EEG. On prolonged 24-hour EEG recording, the likelihood of picking up some epileptiform discharges is much higher, in the range of 80 to 90%. But again, this means that 10 to 20% of the time, even prolonged EEG can be normal in a patient with epilepsy. Several routine 30 to 60-minute EEG recordings can produce the same yield as a 24-hour recording, but may be less practical. To think about why some patients with epilepsy might not have epileptiform discharges, we can consider a couple of things. Here I have shown a coronal section of a brain. I have placed the approximate position of the standard EEG electrodes on this image. The two major determinants of seeing a scalp abnormality are the area of cortex involved and the location. For example, I have shown here a star which represents a small area of cortex that has synchronous abnormal electrical activity. Because this area is small, it might not be picked up by the overlying electrodes. If a larger area is involved, such as shown here, it might be more likely that this abnormality would be picked up by scalp electrodes. In general, 10 to 20 square centimeters of cortex has to be involved in order for the abnormality to be consistently demonstrated on scalp EEG. The other main determinant of a scalp abnormality on EEG is the location of the synchronous cortical activity. In this example, I have shown a very superficial area of cortex involved, which might be more likely to be picked up by scalp EEG electrodes. If a deeper area of cortex was involved, such as in the cingulate gyrus, shown here, in the mesial temporal structure, shown here, or in the insular cortex, shown here, it may be less likely that such abnormalities would be picked up by the more distant scalp electrodes. In this video, we have reviewed basic EEG terminology, how EEG data is recorded and displayed, some common EEG patterns, and how EEG may be used in clinical neurology. Obviously, this is a very superficial review of EEG, and for further details, feel free to peruse some of the other videos which explore EEG in further depth.